Hey guys, this is John Zombro with the Lifetime Athlete, and thank you for being with me today. I'm going to speak about this week's topic, which we have been covering here in May, in Human Locomotion Month at the Lifetime Athlete, and this week we're looking at plantar fasciitis. That topic was the subject of our most recent master class, as well as an article and a podcast, and I wanted to provide some of the same information for our YouTube viewers. I'm in the office today, and in talking about plantar fasciitis, the first thing I would say is if you'd like a little bit more information regarding foot function and pronation and supination, check back to the video which came out last week on that topic if you'd like. Any talk about plantar fasciitis should begin with anatomy. Exactly what is the plantar fascia? Well, it's essentially a sheet of tendinous material known as the plantar aponeurosis or aponeurosis, depending upon how you like to pronounce that. And it runs roughly from the heel to the base of the toes, or more specifically to the base of the proximal phalanges of each toe. It's made of strong collagen fibers, primarily type 1, very much like rope, and the plantar fascia is marginally innervated and relatively avascular. It doesn't have a lot of circulation going through it like a muscle belly would, and it's a non-contractile or inert tissue. In terms of function, probably the best way to describe the function of the plantar fascia is to say that it operates as a windlass mechanism. And a windlass mechanism, at least in this case in the foot, is essentially an arch elevator. So during the stance phase of gait, as we are going past mid-stance and approaching heel off, our calcaneus or heel bone will invert, or the top will roll outward, and this begins the process of resupination that we went over last week. Relatively speaking, the first toe is going into an extended position, and this is a passive or not active process. The plantar fascia, not being a muscle, simply helps us to shorten and lock the foot and make it a rigid lever for push-off. When we look at the diagnosis, plantar fasciitis, simply let's look at the words. Plantar refers to the undersurface of the foot, and itis essentially equals inflammation. This is usually most prominent at the medial calcaneal tubercle. The discomfort can often move into the arch and midfoot or medial heel, and some of the symptoms will include tenderness or pain throughout that region, often worse in the morning, and irritated by activity. When we look at the etiology or the causology of plantar fasciitis, it's essentially a failure in load management or an inefficient stress-strain relationship. Ineffective stance mechanics, especially a failure to resupinate the foot, and that's that converting from a paw, which the pronated foot is a paw, and it's helping us to adapt to the ground or support surface, needs to turn back into a claw for push-off. So if we're inadequate in achieving that resupinated status, this results in the plantar fascia being under increased tension, and our body is basically trying to use soft tissue to make up for a bony or skeletal insufficiency. And this is a recipe for disaster. Anytime we have soft tissues doing the work of bone, and it's really an intensity problem. In other words, these poor mechanics are increasing the intensity of loads with each ground contact phase in the foot. A secondary issue for plantar fasciitis is excess loading volume. In other words, like say, for example, if you walk or run 5 miles a day, but one day you decide to do 15, that may cause an overload or what's known as an adaptation lag, where your tissues just didn't have enough time to build up to that level and thus can become inflamed. So these things altogether form the classic job description problem. Tissues get peeved when they're asked to do something outside of their primary design or role. Often, what's also related to the development of plantar fasciitis is a loss of mobility somewhere, and many times that's in the case of ankle dorsiflexion or shin angle not being adequate. This mobility is often brought about by stiffness within the ankle joint itself, and also myofascial limitations in the Achilles and calves. What this can do is it can cause a slightly early heel off in that stance phase and that pop up before the foot has stiffened and is ready to accept the push off forces, thus creating excess loading on the fascia. So for an initial treatment, once we know, okay, here's the fascia, here's how it works, here's what happens when it gets injured, we want to be conservative early. So in an acute phase, when that's acutely uncomfortable, we want to heal and get pain-free. So using a tissue stress model, we should temporarily decrease loads, both in terms of the magnitude at each foot strike, stressing that fascia, and also the volume or number of strikes occurring over a day. This allows the body to repair itself. We need to decrease, but not necessarily eliminate weight bearing and ambulation, because we need those things for circulation and tissue remodeling. In this initial phase, it's important to support the foot and control the pronatory forces, and that can be done with shoes and or orthotics when the case is appropriate. And we want to minimize barefoot exposure when we're trying to heal this tissue, and that's different from how I'll manage it in the later stages. One of our goals is to maintain normal tissue length with some gentle stretching and active range of motion exercises in a non-weight bearing status. So that might be doing things like increasing dorsiflexion mobility and stretching the foot, ankle, and calf using a rigid strap, or working in that same plane against elastic resistance to maintain some function and pump circulation. Sometimes we use night splints to hold the foot at a neutral angle during sleep so that the healing tissues don't shorten and essentially re-tear upon weight bearing in the morning. But what I found is that's not always as necessary as perhaps once was thought if we do those previously mentioned things correctly. You can also manage symptoms, and there's nothing wrong with that, as well as inflammation, using things like ice or contrast therapy, as far as heat and cold alternating, manual therapy. Efficacy is not very high, quite honestly, with the use of most medications or injections for this problem, because we have to ultimately address the mechanical loading issues, and the same can be said for the surgical procedures which exist for plantar fasciitis. We want to maintain conditioning always as lifetime athletes, so being in the pool or on the bike or spending more time in the gym working on the trunk or upper body is entirely appropriate while we're taking this acute phase healing break. When done well, and this is where I want to mention this in particular, it only takes a few days to a few weeks to get some healing to occur in that injured fascia. Where people get into trouble with this chronic, months-long, frustrating journey is they're not managing loads or reducing them adequately to allow the body to start healing and rebuilding the tissue. But once we've got that done, we got to move into advanced treatment. And so with advanced treatment, we want to now think about being somewhat aggressive later, always being sensible and progressive, but our real goal is to ensure the durability and the reliability of this tissue. So we want to correct overstriding and excessive heel striking patterns and eliminate breaking and slamming down forces within the foot, which those things can cause. Once we've got that relatively pain-free athlete, we're going to begin to address mechanical problems in weight bearing. And so we're going to look at mobility restrictions and improve those and all those factors like strength, power, endurance, balance, and agility. And we'll do that by utilizing static stretching. And with static stretching, the hold times may vary, but we'll be essentially working on creating some increased length in muscle tissue. We will isolate out various muscles, including the gastrocnemius, the soleus. We'll try to load into the foot and fascia itself in a controlled manner. Also, it's very important during this time that we work on maintaining good mobility in all of our foot tissues, including the fascia, and there are a number of ways that one can do that, both with manual therapy or other devices. We want to achieve mastery of basic positions such as sitting on the feet with toes folded, sitting on the feet with toes pointed, and maintaining a full squat with heels down with a really good shin angle. Those things are very important to have a basic level of functionality in our bodies. From there, we'll go into utilizing eccentrics, and that might be done bilaterally to unilaterally and unloaded to loaded. We'll consider the use of concentrics where that is indicated, and ultimately get into isometrics, which are very powerful in addressing tendinopathies. From isometrics, again, when the time is right, we'll move into plyometrics, and these can be done at any number of levels of challenge, but we're going to be doing some various jumping and hopping and landing maneuvers, and that can be also done bilaterally as well as unilaterally. The key here is to always keep what we're doing within the limits that we can absorb and control. So once we've gone through many of those progressions for foot strengthening, and we've worked from bilateral to unilateral, light to heavy, slow to fast, linear to multi-directional, gentle to ballistic, simple to complex, and so on and so on, we are getting ready to move into prior levels or even advanced levels of training. It's important as we go through this process that we always regress if soreness escalates, and in fact it's most appropriate to occasionally have a deload or plateau period intentionally planned in the training. That could be a few days or a week out of every several. It just depends on the athlete. Ultimately, we get into movement pattern optimization, where we're trying to improve total neuromuscular control and the economy, or in other words, the form and the energy management, as well as the efficiency or the force generation or horsepower output of the body. All this leads to effective motion for our lower extremity and then our total body. Sometimes people talk in terms of chains and trains, and that's fine to do, but ultimately we want to have every part of the body integrating and working together seamlessly with symmetry. So one of the things I'd say in accomplishing all that is you want to have a great PT, because this really is the wheelhouse for the physical therapist, and have your local physical therapy professional help you with this problem, or seek one out like me in an online capacity. So now, training progression. We want to understand some key words: frequency, duration, volume, and intensity. It's really important that we progress only one of these variables at a time, and really think of how the tissues can tolerate and absorb this loading. So frequency, as you would imagine, it's how often, such as daily. Duration is how long does a session last, and that could be in terms of time or distance or other measures. Volume is essentially frequency times duration. So if you're doing 5 workouts a week and they're an hour long each, you've got a weekly volume of 5 hours. I know that's obvious, but it's good to mention. We want to make sure that we incrementally advance this and don't overshock or overload the tissues. We always want to get to that point of volume that works best for the needs and the goals and the body that we're dealing with, and stay somewhere between minimal effective and maximal absorbable dosage. Lastly is intensity, and that's really the fitness maker in many cases, or the conditioning maker. Gives us that ability to achieve peak performance. And we want to look at how hard we're doing things and begin to apply those where it's appropriate. But a word of caution here, we need to be careful with intensity, because it can be like kryptonite in the returning to sport athlete. In this case, have a great coach. Again, work with one locally, or if you think I'm decent, hire me. Now, long-term prevention. It's really this. We want to maintain ideal function in our bodies. So try to have enough mobility so that you have the requisite amount of mobility to gracefully take your body through all the movements that it needs to do. And then contrast that or complement it with the stability that you can own and dominate the shape and position that you put your body in, no matter what that is. You do those things and you're going to be functioning very well. we want to maintain some amount of conditioning for connective tissue integrity. So those very things like the isometrics and the plyometrics, which I sometimes will call durability work. Yes, they do enhance performance to some extent, but they also can contribute to injury prevention and avoidance. And I know that's a very debatable topic, but if we are applying these things intelligently, we can get something out of them. And that's really the final message. All of our programming should be effective and well thought out. It's not really rocket science, but it's human peak performance science, and that is indeed a fascinating topic. So thank you for being with me today. I hope you enjoyed this little journey and kind of office discussion about plantar fasciitis. If you'd like more information, check out some of the resources that are available at thelifetimeathlete.com. And until then, this is Coach JZ, or until next time, this is Coach JZ signing off from the Lifetime Athlete, where you can achieve peak performance at any age and be hard to kill.